Welcome. I think you recognize us. This is, I'm Peter Kahrilas. This is Daniel. Oh, yes, it is Daniel Sifrim. So we're opening the session on esophageal diagnosis, new developments, new questions. The first presentation is going to be given by John, who I don't think any of you know, entitled GERD Diagnosis at Endoscopy, Mucosal Impedance, Endo-FLIP, and More. John?
All right. Well, thank you very much. And I apologize ahead of time because if those of you who stuck around last night, they actually saw about 80% of this talk. And I'm a little bit lazy now, so I wasn't going to change it that much. But essentially, the concept was pretty similar in terms of really making that first index endoscopy, that point of care that almost everybody's going to get, to be a really great opportunity to improve our patients' health. And if you look at value-based healthcare, you know, a few of the tenets are frictionless entry, getting people in quick, careful curation, you know, making sure they're seeing the right person. I don't think my thoracic surgery colleagues want to see a functional heartburn patient, and you know, so that's kind of our job. And the other thing is really expediting care, you know, getting to the right answer quickly. So, you know, in that respect, I think there's a lot more we can do in terms of the endoscopy suite. These are my declarations, as I said this morning, quite vast. So when you think about patients and you see these people in clinic, and this is going to be more clinically driven or focused. You know, patients with heartburn, regurgitation, chest pain, dysphagia, you know, your differential is pretty wide. You know, it could be GERD, could be EOE, mechanical obstruction, motor disorder, or a functional disorder, or a DGBI. But the bottom line is that no matter which algorithm you look at, you know, all roads lead to endoscopy. You know, you're going to have to get in there. You're going to have to make sure there's not a significant inflammatory condition or a significant obstruction, whether it's mechanical, related to a tumor or stricture or some other type of esophagitis. And over the years, and I mean, we know that you know, this is important. As you saw multiple times today, we stratify severity of reflux disease based on esophagitis grade. And I think you could also see from the talks this morning that, you know, the flap valve and the flap valve grade and looking for hiatus hernia is important, because we know that if you have a significant hiatus hernia, you know, 5-7 centimeter hernia, you know, that's not going to respond to PPI when people are complaining of volume regurgitation. So these tools are very important. Now, they're also important for ruling things out and making sure that there's not cancer and stuff, and reassuring patients, but they do have value even at that index point for reflux severity and assessing the anatomy, and also predicting what the likelihood of response to therapy will be. Now, that being said, you know, in terms of primary care, you know, the model for evaluating reflux is typically, if people don't have warning signs, is to give them an empiric trial, which I don't think is unreasonable. I do think it's unreasonable, though, to give people an empiric trial for 4 to 8 weeks, and then they come back and don't respond, and shift them to another PPI and give them another 4 to 8 weeks, you know, treatment, and double it up, and then 6 months later finally think about, well, maybe we should figure out if it's reflux. God bless you. So really, you know, when people get to the point where they're seeing a gastroenterologist, at least in my practice, you know, many of these patients have been on 2 or 3 PPIs. And that gets to the gist of this particular patient. This is a typical patient. I used to say months, probably about a year and a half now that I've seen this patient. But, you know, 42-year-old male, came in with heartburn and chest discomfort for 6 months, seen by the PCP, had an exercise stress test and a cardiac CT, both were negative. In terms of his immune systems, you know, it was the pandemic. He gained a little bit of weight, but no trouble swallowing, no evidence of bleeding or anemia. So once again, you know, they tried an empiric trial, 20 milligrams, he said, of omeprazole, said he had a mild response, increased that to BID for another 4 to 6 weeks, you know, and 20% better. Then for some reason got put on pantoprazole, no change, switched to dexlansoprazole, 60, big guns, maybe 20% better. So really when you ask him, he has no idea how he's doing. So 5 months later, he's finally referred to GI, me. 6 months later, endoscopy was negative, 7 months later, he finally had reflux testing. He had a 24-hour pH impedance off medicine, and it was normal. And essentially 8 months later, he's being treated with cognitive behavioral therapy and hypnosis. That's not very effective management. So I don't think this is value-based care. So probably a better model, and I think you saw that in Reina's talk this morning, is maybe we should start thinking about doing upfront testing a little bit more. Maybe we should be more aggressive so we actually know what we're treating. So, if you look at these patients who come in, if they fail, a 4 to 8 week course of PPI therapy, a standard FDA dose, or if you want to do double dose, and you're not sure what's going on, you probably should investigate, and an endoscopy is a really important tool, and the classic, evaluation will be to look for esophagitis, evaluate for stricture, eosinophilic esophagitis, maybe get some biopsies, assess whether or not they have a significant hernia, and whether their flap valve is obliterated. But, a lot of the time, the examination is normal, and we see the patient in recovery, and, they ask us, well, why am I having this? And we say, I don't know. And they look disappointed. They want us to find something. They want an answer. And if you don't have, a positive answer saying, I know you have this, it would also be good to say, I know you don't have this, and give them more information so you can start them on their care journey. But what if you could do everything during that index endoscopy? Say, for instance, the patient came in and they had symptoms of regurgitation or chest pain or whatever, and you put them through an endoscopy, it was negative. You could evaluate their motility, tell them you don't have achalasia or you have normal motility, and you can tell them, yes, you have reflux, or you know what, no, you don't have reflux. So literally at the end of one visit, you could essentially give them all of that information. It doesn't mean that we're going to get rid of reflux testing and high-resolution manometry. I know that's the big fear. We're all wired to resist and fear change. But, it would move that into a more complementary role or a specific, symptom-based functionality. But it's hard to debate that that's not a good thing or a good objective. To expedite the care in a reasonable way to make our patients either reassured that nothing bad is going on or actually getting to the point of what they have and treating them. So it's interesting because the wireless capsules initially were developed to be performed during the index endoscopy. That was the whole point. But unfortunately, because of insurers and payers, that doesn't happen. They need to have an endoscopy that's negative before you can do that. And especially with the calibration issues that there used to be, it kind of fell that people would get that test as a second test, and they'd have to come in for another endoscopy. That was not very efficient, right? And at that point, you might as well do 24-hour pH impedance or catheter-based reflux testing, because that's probably cheaper than bringing people back for another endoscopy and the wireless capsule. And I'm not going to go through this data again. Reina showed it. It was shown a couple times. But the bottom line is that with that particular test, if you did that during that index endoscopy, you placed the wireless capsule, and they had 0 days that were negative, in basically 4 days, I could tell them, you know what? You don't have reflux. You have probably functional disease, and your best bets are neuromodulators and cognitive behavioral therapy with possible hypnosis. And within that week, maybe not that same point. And really, the AGA guidelines have really looked at this as a stratification tool. It's not replacing pH impedance. It's not replacing manometry. It's just putting pH impedance and manometry in a different place, where we can get to most of the answers without actually having to put our patients through those particular catheter-based studies. And then if you start thinking about this, there is a lot more that we can do in terms of getting to that point. But as you mentioned, or as has been mentioned, we still like 24-hour pH impedance, and we will use that to assess the patients with proven GERD and put them into a better phenotypic category. So it doesn't get rid of pH impedance. You don't throw the baby out with the bathwater. You kind of bridge people along, but you use it in a much more precise way, a much more personalized way. And now we get to FLIP. Now, I will tell you that, in terms of GERD, FLIP, that's probably its weakest point, where it has value. I mean, its best value is ruling out a major motor disorder or proving that someone has normal neuromyogenic function, and a normal opening EGJ, essentially ruling out a major motor disorder. And that's where it has its best value. But that could be useful in these particular patients, but there might be some other things we can glean from this. So where can FLIP help in the evaluation of GERD? Initially, when I started using FLIP, the main focus was really on defining the anti-reflux barrier. And we were looking at EGJ DI at different volumes. We were using an 8-centimeter balloon in the beginning, then moved to the 16-centimeter balloon. And I have to say that when we were doing studies and we were trying to correlate that with reflux parameters, we probably were picking the wrong parameters to look at that in terms of the fluid dynamics that are associated with EGJ opening. In addition, the other thing that FLIP can do is assess esophageal clearance. There are a lot of different ways to assess esophageal clearance. You can primary peristalsis with liquid swallows. You can do a solid test meal. You can do a barium esophagram. You can look at clearance waves in 24-hour pH impedance. But certainly, if you blow up a balloon and the balloon doesn't move and there's no peristalsis, there's probably going to be bad clearance. So it can effectively assess esophageal clearance. Now, despite that fact, one of the things we also was, looking at FLIP with low-hanging fruit was, assessing achalasia. And it's a really great tool to see if people respond to therapy or whether or not they had a poor response. And I will tell you that, now I don't do a pneumatic dilation unless I have FLIP. And we still do a lot of pneumatic dilations. And it's really nice when you do that and they start out with an abnormal EGJ-DI, you do that, and then boom, there are 4 and their maximal diameter is 15. You feel good about that. You know you've had a pretty good response and they probably don't need further therapy. Our interventional endoscopists and surgeons use it in the OR, and they love seeing that effacement and opening after they perform their myotomy. Now, when we looked at it though in GERD, what we found was that, yeah, if we compared controls to GERD patients, the EGJ definitely did open up wider if we categorized the patients. But probably the issue here was that this was mostly focused on the crural diaphragm. In fact, when we were doing some simultaneous fluoroscopy images, we could clearly see that the impingement in people with hernia was at that crura. And that's really what was probably driving a lot of the EGJ distensibility in these GERD patients. Now, I'm stubborn, and despite that, I said, you know what, I'm still going to try to correlate EGJ DI with acid exposure. And this was a paper that Dustin Carlson published in 2018, and it was negative. It didn't really show a good correlation. That was followed up, or maybe Mark did it before us or right after us, and showed, yeah, acid exposure does not correlate with EGJ distensibility index. And you know what? It probably shouldn't, because esophageal acid exposure is more related to hernia and peristalsis than it is the opening dynamics of the EGJ. And really, probably what we should have done is a 24-hour pH impedance looking for proximal extent and volume liquid reflux and seeing if that was what was really different. Now, it might be the same, but that would have been the more educated study. Now, the other thing that FLIP showed us that we really didn't plan on, but it would really define hiatus hernia really well. And the other curious thing is that you would see patients who have essentially normal anatomy, no separation on high-resolution manometry, and you do the FLIP, and they have a new hernia. Maybe not a new hernia, but maybe their phrenoesophageal ligaments were pretty weak, their crura was wide open, and you blow this balloon up, and you see this separation. And we did, in a retrospective study, show that this mattered in terms of symptom and acid exposure. So this inefficiency or ineffective EGJ that we could elicit this hernia with a provocative maneuver like FLIP, did show us that it had some value potentially in engaging the anti-reflux barrier beyond a simple number of distensibility index. And then, of course, the patterns of opening, they're pretty easy to define. And, of course, the patterns of peristalsis are also pretty easy to assimilate into your practice. Here are a couple of normal swallows with normal opening, beautiful primary peristalsis in that same patient. That's their FLIP. You can see the beautiful racks, and the EGJ is wide open. Here's an achalasia patient, absent contractile response, and the EGJ is not opening. Now, what Dusty did that was very smart was that he did have some evidence of clearance, and he had thought about this a little bit more, and he went back and looked at how well acid exposure correlated with clearance, looking at the rack pattern. And he did show that if you had racks, you literally had less esophageal acid exposure, which makes sense because, as I said, that kind of dominates esophageal acid clearance, peristalsis, and a hernia. So it had value in predicting, or at least associating with, esophageal acid exposure, but not the way we initially thought it did, and instead focusing on the contractile response. And this was also interesting when we started thinking about our scleroderma patients. So these are high-resolution manometry images of a single swallow in 5 different scleroderma patients. And these are what you see on FLIP. And you can clearly see these patients here have classic scleroderma esophagus, but some of them have racks, some of them have a little pressurization here, and some of them are essentially dead. And what we're finding, and this was a small series that we published, but what we found was that, yeah, these patients who have absent contractile response on FLIP and primary peristalsis on manometry are much worse off than the people who have some preserved secondary peristalsis. So highlighting that this may be keeping people beyond that tipping point where they start to develop significant reflux. So I do think now we have an opportunity with these devices to go in on that first day to do a pretty good assessment of EGJ opening, and I will tell you that if you look at the data as well as manometry, and then also an assessment of peristalsis, not primary peristalsis, but secondary peristalsis, like using the same neuromyogenic function, so you can extrapolate back or back propagate. And we do have a device, the wireless capsule, that can actually assess acid exposure that you can place during that index endoscopy. So in 96 hours to 1 week, you can answer all the questions for this patient practically and feel very confident that in 1 week you have the answer. Can we do better? Well, I'm not going to go over the same slides over and over, but as you saw in a better presentation than I'm about to give, that you can measure mucosal impedance. And I thought this was genius when it first came out. It made sense. I have to admit, I am very skeptical of pH impedance, MNBI, in many aspects because I just don't know that it's contacting the wall all the time. And I'm not exactly sure that that signal is permeability of the mucosa versus just some liquid. We know that people with reflux have poor clearance, especially if they have a hernia, and there's a little bit of liquid there. How do you get rid of that? You can't, and especially in the supine position. So, it bothered me a little bit, but this tool where you could actually go in, you can see that there's no liquid there, and prop this mucosal impedance probe against the wall seemed pretty ingenious. And they had some decent data looking at this, and of course, looking at MNBI and mean impedance, you could see that maybe there is some logic here, biologic plausibility with looking at baseline impedance, these other parameters that Nicola talked about, and these correlations between these things. Maybe this could help us. Maybe this could give us a line in the sand where we could at least say, you're normal, and you don't need further reflux testing, all right? So the Vanderbilt group came up with another technology, which was an evolution, which was this balloon. And these patterns are pretty cool. They're very much like the heat maps that you see on high-resolution manometry, right? The colors give you some indication of the ohms. And these patterns look pretty cool. And, when they went back and looked at how these performed, and you saw the slide already, I'm not going to go through it again, but, it looked like there was a separation in terms of being able to predict normal versus reflux in EOE. Now, certainly there's a lot of overlap, but definitely biologically plausible, and it was just about making the hardware work. Well, now there's a new evolution. This is the endo-cap, where now, instead of putting out a probe or a balloon, and the balloon was pretty hard to use, to be honest. I didn't like using it. But now we have the endo-cap, which is now something you attach onto the scope, and you just press it up against the wall. And you actually get that same pattern that you'll see from the previous balloon-based catheter system. So I do think we're on the cusp of having a point-of-care screen for GERD during endoscopy. Now, there's a lot of interest, and this is another technology called mucosal admittance. It's kind of the reverse. They were a little concerned about maybe some patent infringement, but anyway, so a little bit different technology with a needle and a current and a pad on their shoulder. Unfortunately, they didn't have very good data, and they didn't show that they could separate out. Now, it might have been a small study, and there might be a type 2 error in that study, but the bottom line is that they weren't able to discern GERD versus non-GERD. So I don't know that that technology is going to make it, but we still have the EndoCap, which at least appears to be a little bit more simple. Oh, sorry. Now, you heard me mention this before when I asked a few questions, and I think this comes down to the whole, situation here. And when you start to think about reflux disease, it is not going to be determined by a single value. You put all of this stuff, all of these pieces of information, their hernia size, whether they have one, their BMI, their demographics, their belching patterns, all of this stuff, whether it's manometry, FLIP, HRM, postprandial, 24-hour pH impedance, all of these things can feed into a convoluted neural network and in some way define a phenotype. Because GERD is a heterogeneous disorder. It's not one disorder. There's some people with anatomical issues. There's some people who have belching issues, and they reflux when they belch. And really, I think, in the end, regardless of which one wins, and it's not a competition, these are complementary tools. You use your mind to use these together to get to the right answer. I think we owe it to our patients to actually get this done during that index endoscopy when they're sleeping and they're happy and quiet without having to ram a catheter down their nose, which we have shown and published does cause some significant trauma. So this is a much more, in my mind, humane way. And I always say, how many people in the audience have had a manometry? So not everybody. So not everybody understands it. How many people have had 9? Yeah, it's not fun. So there's a few people. I think Dusty's getting there. But anyway, the bottom line is I think we are evolving. Technologies are getting to the point where we can use that index endoscopy to answer all the questions. And with that, I will end and open up to questions. I'm sorry for the redundancy if you were here Monday night.
Questions? Any? Roberto over here.
Thank you, John. Very, very interesting. And I'm of the idea when I do the first endoscopy in many cases to, if possible, to get wireless pH, for instance, at the moment. But what we have to assess first is the clinical picture, because if you have the high probability to have eosinophilic esophagitis, even if your endoscopy is normal, you've got to wait for the biopsies. I cannot go on. So if you have a symptomatology of mainly dysphagia and in allergic patient and whatever, then I wouldn't couple at the first endoscopy some other costly measures. That's the only point, that we always have to have the clinical picture first in order to understand in which of the patient to do this and combine those.
So I apologize because I had slides on EOE last night and slides on achalasia, which would have helped this. But so I totally agree. You need to know what's going on with EOE. And I do think that there's the possibility, and I will show, we just had a paper accepted in Gastro that shows that if you look at FLIP in terms of distensibility and the contractile pattern, we can predict PPI response better than anything. And we can also predict who will not respond to a PPI and who you're going to waste their time with. So this, tool can now actually assess esophageal or eosinophilic esophagitis severity in terms of the mechanics. It can predict possible PPI outcome. And we do know that the EndoCap, one of the features is that it could possibly tell you whether or not this is eosinophilic esophagitis. So once again, opening up the opportunity that you could answer everything at an index endoscopy. And I think instead of worrying about this, because we're all physiologists and we love manometry, this is what we should aspire to. We should aspire to getting all that information so that our patients can get a quick diagnosis and painless.
Well, the payments part is the key there because you know it's tough.
Well, I mean, I think you can model this. If you look at the cost saving downstream of people who are, and you saw this with Raina show in terms of the cost, the inappropriate PPI utilization, the multiple clinic visits, the repeat endoscopies, and the manometries. I mean, all of those things add up too. So if you actually look at it, it most likely will be cost neutral. Now, of course, playing with the price points is going to be very important as how these things evolve. But remember, you're already there, right? The endoscopy is the most expensive part of all of this, right? No matter what, it is. You know, the anesthesia, the whole part for us is the most expensive part for us. So adding on a capsule or an endo cap and stuff like that, it's going to be incremental in terms of the overall cost. And if you look at the upfront cost versus the downstream savings, I think it could be modeled so that it's at least cost neutral. And remember, if something's cost neutral, but it has the added benefits that people know the answer in a week and they don't have to get a catheter and they're not upset, that should be enough for it to win. And I said these things are not winning or losing, but they move into different realms.
John, what do you think about transient lower esophageal sphincter relaxations that were ignored during the whole day? Even the talk of Radu was called transient LES relaxation. He didn't mention it. You are not mentioning it.
I mentioned it.
What is going on with that?
Yeah.
You mentioned
Well,
you mentioned it.
Well, you obviously, because of these tests, you can't define the transient lower esophageal sphincter relaxation during endoscopy, although I will cite Benson Massey's work, where he actually did look at this using a combined endoscopy, where if you insufflate the stomach, you will eventually see it pop open. And that typically is a TLASR when that happens. It's not the blown out venting, and you can kind of tell the difference there because it sits there and it's holding and then it just kind of pops open. But once again, I think that I'm not going to define TLASRs and the mechanism behind reflux. I'm just trying to figure out if the patient even needs that tool. And it may be that EndoCap replaces wireless capsule. And we use high-resolution manometry and pH impedance for those difficult patients who have proven GERD that we're trying to figure out that mechanism and trying to figure out if they're supragastric belching. Although I will say, you know who's supragastric belching. You don't need, a manometry and a 24-hour pH impedance many times.
I heard a talk by Inoue in Switzerland when he was looking how people were belching, filling up the stomach and looking at the air coming out. And I told him, I don't think that it's very physiological. What do you think about that?
Yeah, so I saw that. I saw that too. They're obviously they're a lot more aggressive with this than we are in terms of that. And I think he is going back that route of Benson Massey. The key though, when you do that, you need to use a thin, catheter, just like a manometry catheter, and insufflate there. Because if you do use a regular size scope, that's already causing some opening, right? That first pop that happens with opening, and Hans Gregerson's probably here can explain this much better than I can, but that first opening requires the most energy most of the time. And when you're already open with those 10, 11 millimeter endoscopes, it's a little bit different. So yeah, there may be that if you can do that and record that, you can see TLASRs, but you see TLASRs in normal people, right? Probably I know that when I've had my endoscopies unsedated, I'm belching up and that'll happen to someone who doesn't have reflux. So it's interesting to think about, but I don't know that it's gonna come to prime time.
If there are no other questions, I think we'll proceed. Thank you, John.
Thank you.
Okay. We will continue with the second session on a different technology, which is ambulatory high-resolution manometry. This will be presented by Alissa Jell from München in Germany.
So thank you for the introduction, and it's an honor to speak here, actually. So it's hard to give a good talk after John Pandolfino, but I will try my best. And so I start with my declarations, and then I will take you to a journey on ambulatory esophageal diagnostic. So when we talk about ambulatory diagnostic, we've heard a lot today. We most of the time think about pH or long-term pH impedance manometry. But when we had the talks yesterday about the high resolution manometry, we all came back to the same topic. What do we examine? So when we have a patient lying in our laboratories, that's not quite physiological. So when the patient is lying down, most of us don't eat lying down like the Greeks. So that arised our intention to assess the esophagus furthermore. So in June, it will be 10 years since we have been performing a long-term ambulatory high-resolution manometry. So we had to start quite as a peak. And in 2018, I changed the protocol. But why? With the long-term manometry, we figured out that the additional tests like standard test meals, prolonged evaluation after the meal, about 30 minutes, will give us so much additional information that to this time was not standard, that we can reduce the amount of examination time. And then obviously COVID hit us, so we didn't perform any more as we are not allowed to perform high resolution long-term manometries. But actually I have to confirm the idea is not new. So in the early 90s, there was a diagnostic recorder. It was big like a brick, and it was quite heavy. So the patient, if they had these long-term manometries down there, had a little suitcase with them because it was a water-perfused system. It was 3 channels of manometry, and there was just the event recorder. So whenever the patient pressed the button and said, now I have the pain or whatever, it just would have recorded the last 10 seconds. So it's nothing that we really can rely on. So the technical evolution has made it possible that we have nowadays state-of-the-art manometry catheters, and we have a recording device that is coming handy. So what we have is we use the typical 10 French solid state sensors. We use 36 pressure channels and the 15 impedance measurement elements. So if you really go the extra mile to assess somebody for 24 hours, I think it's more than logical to take the impedance as well and not just stick to the manometry. The device is lightweight. It has a high sampling rate in regards to the first system in the 1990s. And the patient has the possibility to punch in the information, say, okay, I'm lying down, I'm awake, I have pain at the moment, I'm eating, I'm drinking. So what we always do is we start with our standard HRM protocol, then the standard test meal and the prolonged examination about 30 minutes afterwards. And then we are not, we don't have to change the system. We can simply disconnect it from the computer. So the patient doesn't have to get a new catheter in, new placement, new acclimatization to the measurement. We just disconnect it. So every of our patient has this setting, and whenever we feel, okay, we could get some more information, or we specifically didn't get the information during our assessment, we can prolong the examination. The recording unit has the possibility of up to 26 hours. But what do we do when the patient comes back the next day with all the data? So the data is huge, not in saving space. So 1.5 gigabyte is nothing in comparison to terabyte and co. But the pressure events, when we all sum it up, we have 220 million data points per measurement to look at. So in the beginning, I did it myself, and it was like for 24 hours of manometry, I sat there 3 days. So it's not any possibility feasible in clinical practice. So what we do now is we have a qualitative evaluation. So what we heard yesterday, most of the times when you just look at the manometry, you know what you're dealing about. You don't have to have the figures. If you are not sure, then we will concentrate on the events that the patient recorded and triggered. So we look at all the manometry events surrounding these events, and then we will stick to the quantitative evaluation. How do we do it if you don't do it manually, which is insane, by the way? So we have a high-resolution manometry evaluation tool. I will walk you through the single steps with the model for time series data. So to start off with the swallow detection, and I think in every good talk about AE and automatic image detection, there's always a dog. So here it is. But the dog symbolizes we have to find the swallow. So if you have a patient with long-term manometry, you can't tell them, okay, come back tomorrow, and stick to your 30 seconds of breaks in between every swallow. Just remember it, sleep good, have your meals, but remember, keep to the 30 seconds. So we always have swallows getting into each other. So what we did on the first step is that we cut the pictures not like in the time series data, but surrounding the swallow. So then we extrapolated the cutaway area so that we just have the simple swallow for further classification. So when we extracted all these pressure events, we then have to cluster them so that it makes it easier for us to see what we are seeing. So we have 4 big parts. The easiest one is always the artifacts. So whenever they're coughing, so it's easy, they are ruled out easily. Then we have the regular swallows. That is the next easier part detected by the algorithm. And then we just state patterns that are different to these normal swallow patterns, and they have major difference to those swallows. And so when I do the evaluation, I don't have to mark every normal swallow. I just have to mark a few that are representative for the whole normal swallows, and then I can concentrate myself on the major and minor difference to swallows. Depending on the patient, it will take me 30 minutes to 1.5 hours. So it's, for the first time, feasible, but it's not the top at the moment. So when we talk about the data, it's not all that we say, okay, now we know what we're talking about, but we have a patient at the center of the examination, so we have to address this as well. The patient compliance is crucial to a long-term examination. So what we saw in all our patients, about 65% of patients stick to these long-term measurements. The thinner the probe, the longer they accept it, and the more visits to doctors they already had, the longer their his past medical history, the more easily they will stick to the 24 hours. But we want to assess all of those. So the under 1 hour group is typically these patients who say, okay, I will stop after the test meal and a half an hour after checking those, and they say, no, I'm done. It's not that big of a problem I have. I will figure out another way. Then the next ones are the 10 hours, so they stick through whole the day, but say, okay, I will go to bed and I will do no sleeping. I know I will just rip it out. It's so not my thing. The problems can't be that big. Maybe you already saw what you saw. So, and these 2 patients are the most interesting ones. So we concentrated on those the next few examinations. From the technical side, there is quite interesting thing, the probe dislocation. So when you have the probe just for 1 hour, you can quite easily fix it to the nose. But when they eat and they swallow and they lie in bed and they get tangled in their catheter, then they will move. But what the experts on USO, basically everyone already saw, we have a bigger problem. It's not the probe dislocation, it's the drift of the probe. So it's not that obvious always, so I just picked the most brilliant example, but we have the temperature and probe drifting. So when we perform long-term manometry, starting with the first 1 or 2 hours, the probe starts to drift. So when we compare the IRP, the DCI values itself from the beginning of the examination to the end, they don't match. So what do we do then? When we have the cluster, we just focus on those early patterns. So then we can say, okay, it's the same act of swallowing. So it looks familiar to our algorithm. So we suppose the pressure will be the same. So for the probe drift, we can decalculate the drifting. But what we also saw, and the way did publish it, it's depending on the catheter. So if you have the standard French probe, it has a quite significant pressure drift during time and in the high pressure zones. When you take the smaller, the child catheter, it's not that of importance, but the most effect is in the combined impedance manometry catheter. So that's what we're basically using when we say, okay, we do the extra amount of work for long-term manometry and we do the impedance, so we have the weakest catheter actually at the moment available. And last but not least is the problem we have to focus. We don't have a standardized protocol, so we don't have any normative values to deal with. So I just will show you some findings that we and other working groups already had from long-term manometry. So I think we all agree that we have to provocate testing, and in the beginning we had those only in the long-term manometry. Nowadays with Chicago 4 it's in the normal assessment. So the provocate testing is like longer evaluation, and you can see like outflow obstruction during standard test meal and so on. But it's not what's qualifying for 24-hour long-term manometry. So what we are looking for are those patients who complain about during nighttime some pain. So this is a patient who experienced, I think it was 2:30 a.m. There's a heavily spasm in the esophageal, and I think 3 minutes later there was the button pushed for pain, and the patient told me, yeah, he woke up and then he got up and he drank something and then he remembered he had to push the button. So it's not that he woke up 3 minutes later. So basically it was a woke up from the spasm, but until he found out how to protocol it, this was 3 minutes later. So we are checking on patients who report of intermittent occurring symptoms who can't be detected during normal or prolonged manometry, and the number needed to screen in our patients so far is 12. So you have to have 12 patients with long-term manometry so that one is getting additional additional diagnosis other than the prolonged manometry protocol. If you compare it to the standard protocol like Chicago 2 or 3, then it was a number needed to screen of only 4. So we see with the protocol evolving, the number needed to screen is evolving as well. So the importance is going back, I have to admit. So Jutta Keller had the publication on 104 patients. They performed long-term manometry on. So in 25 of those patients, they diagnosed achalasia, hypercontractile esophagus or spasm with the standard wet swallowing manometry. When they prolonged it with the test meal, there were already 40 of those patients diagnosed, and with the 24-hour manometry, 52 of those 104 patients had the right diagnosis of their disease. So it's 50% if we just take our time and look longer at these patients we are dealing with. And just to come back, I have a slide on tearless RS, and I will talk about them. So the tearless RS, they occur during 24-hour manometry. We see them quite often, and they often come with spasm afterwards. And predominant, there's also some motility patterns. So all of these examinations, the patient was sleeping. So there was no swallowing, no any other triggerment. And most of the patients showed some motility pattern before transient lower esophageal sphincter relaxations. I can't tell you why at the moment, but it's something that stick into our eyes, that there's something coming before the transient sphincter relaxations, and we're working on this. So maybe now you have 1 or 2 patients in your minds you saw in your career and say, maybe this would have been a good candidate for a long-term manometry. So to sum up, why should you perform it if you are interested in long-term manometry combined with impedance at the best? We offer this examination to all patients with intermittent occurring esophageal or extraesophageal symptoms that we can't detect during prolonged manometry. They typically non-cardiac chest pain, dysphagia. We sometimes have patients with chronic coughing because you can see the cough in the manometry is so great. It's a sharp reddish marker, and then you can check for reflux. So at the moment we're working on the with the catheter company to fix make a probe that combines manometry, pH, and impedance, so that we have all in one. So it's work in progress, and we perform a long-term manometry in patients who have inconclusive or normal standard testing and even provocational testing, but they are really complain on symptoms that are reliable when they tell us. And we offer it also to patients with a long medical odyssey they had gone through. So they had been referred to several doctors and nobody found out. So we give it a try. And with this, I will thank you for your attention.
Are there questions from the floor?
So that was really wonderful, and that technology, I think, is the future in terms of, studying these patients. And the pH probe is a great idea, and, I find that, I didn't really understand reading 24-hour pH impedance until I actually had high-resolution manometry opened up next to it in a window, and I could see what a swallow looked like. I could see what their reflux events look like. So it's very, in my mind, I'm very excited about this technology. And I think if I was a company, I would be going all in on this as a tool to assess these patients once they get to that area where they've been screened. The cough is very interesting. So we looked at this in high-resolution manometry and have a very distinct pattern, these 3 epochs. And then a throat clear has 1 epoch, and you can really separate them out. Were you able to see, like that 3 epoch pattern with cough?
You should explain what epoch is.
So epoch is just like bursts. So they're long bursts. So instead of a retch,
They are these.
yeah. So it's that pattern right there. Were you able to go back and correlate those with cough, because we did this with the acoustic monitoring, just kind of as a validation, but we actually found that worked better than.
No, we didn't count them actually. We used it for another project to synchronize our data. So we had the pH probe and the long-term manometry probe, and had an additional pressure sensor on the pH probe. And so this was quite helpful. If they coughed several times, you could synchronize our data. But I didn't come to the idea to
just a really
count
easy
them.
way to detect
Yeah.
cough. So.
Can I make a comment? We have the system in London, and there are two problems that we find. The first is that a 10 French diameter catheter is very difficult for the patients to tolerate for more than a couple of hours. It's not like the reflux monitoring catheter. This is a real thick, rigid catheter, and this is an important problem.
Yeah.
And the second issue is that we use it for symptom correlation in non-cardiac chest pain. The patients have somewhere during the day chest pain, and we look at what happens with that before. And we had several patients where the stationary manometry was normal, and they had a clear pattern of jackhammer or whatever related to meal-induced chest pain. So I think that in that aspect is a very interesting tool.
Yeah, so the probe is no discussion. It's uncomfortable, and the patient just stick to those probes when they're really suffering. So, and they have been referred to several doctors. Then you see it, the acceptance is quite high. So we had one study with a control group of healthy volunteers. They almost all canceled the examination because they said, okay, it's so unbearable. And the patients, surprisingly, really stick to it because they are suffering so much. But a smaller catheter would be far better, yes.
Jutta Kell from Hamburg. Wonderful talk, thank you. In our hands, less than 10% of patients won't tolerate the probe because they've come so far and want to know what's happening. Yeah, and we gain 50% of extra diagnosis of spastic and achalasia-like disorders with the meal, and another 50%, as you've shown, with the long-term examination. So I really think it's an important addition to what we have now.
Jenny Myers, Adelaide. Just wanted to ask you about the transient lower esophageal sphincter relaxations. You mentioned a small sort of pediatric size catheter versus the adult. Did you see less transient sphincter relaxations due to the size of the catheter? Because the catheter itself could be inducing the unusual motor pattern and the transient sphincter relaxations.
Not the size of the catheter, but the configuration. So we have a slim catheter, and we have one that's coated. So it's like a little bobbly chain. And with this, we have more, and it's way more uncomfortable for the patients than with the slim one. So for long-term manometry, we swapped to the slim one.
One little comment, the catheter does not have a pH sensor.
Not yet.
The reason is that the antimony pH sensor or the glass gets used 2 or 3 times and is broken. And the catheter costs more than 20,000 pounds. So you cannot change the pH sensor in that catheter. That is the reason. The impedance electrodes, they stay as much as you want, but not the pH sensor.
But 10 years from now, when they make the catheter small enough, we'll be having a conference on classification of 24-hour ambulatory pH, manometry, impedance.
Why stop there? 96 hours, come on. Talking about prolonged measurement.
What the format is.
They can sit here.
Oh, so upcoming is a debate. I don't know how they're going to debate, but wireless versus catheter-based testing. Is it time to put away our catheters? Are you going to? How are you going to do this? Sequentially, or
We're sequential. Sequential. And
Too good of friends to have this.
no, we're just going to talk over each other. He's going to talk while I'm talking. No. So wireless versus catheter-based. I'm going to take the wireless side. And
much of what I'm going to say has already been mentioned. Don't freak out when you look at the next slide, when you see the next slide, because I hardly matter. Whereas, look at Eduardo. So
I don't think yours are right.
Well,
I'm going to question that.
you've been questioning everything. So anyway, this is the wireless pH probe. Everybody knows what this looks like. It gets attached with suction that is transmitted to the chamber that's on the probe, and then mucosa that's sucked in is held in place with a pin. That's what it looks like after it's in place. And exciting news this year, we have a competitor to our standard wireless. We have Alpha One from Labry. Advantages of catheter-based monitoring, catheter-less monitoring, is that there is no catheter, nothing sticking out of the nose. So no activity limitations, minimal discomfort, placed during sedated endoscopy. And importantly, there is a fixed relationship to the esophagogastric junction. It's placed 6 centimeters above the squamocolumnar junction. That's where it stays. As long as it's placed right, there is no issue of the esophagus shortening around the catheter. The tip is not going to dip into the stomach. So that's a big advantage. Another advantage is the fact that you can record for up to 4 days. The initial release was 48 hours, but you can do up to 96 hours worth of recording. We'll talk in a second about what the value of that is. Now, there are disadvantages, and I will show some images regarding this. So there's a single recording site, so you can't really tell swallowed acidic material from refluxed material. And a patient can really manufacture acid exposure time if they were so inclined. Typically requires endoscopy, higher expense because of endoscopy, and it can fall off. And if it falls off, it's important to recognize it, but there can be data loss. So study from John from a long time ago showing day-to-day variation in acid burden, not just in patients, but also in asymptomatic controls. And the fact that you can detect this day-to-day variation, pick out a trend of abnormality is a big advantage. And this was a very nice study from Daniel and Roberto, where they looked at patients that were diagnosed with functional heartburn. We can't call that anymore, idiopathic heartburn, I guess. On day one of a 4-day study, they had 50 patients, but only 35 remained at the end of the 4 days. And 15 of these patients had an abnormal pH day when the study was continued past the first day through the 4th day. And you can see at the top, these were the non-erosive reflux disease patients. Did it matter? Yes, it did, because the symptom response to acid suppression was 3/4 of the time with the non-erosive patients, and only half the time, less than half the time, with the PPI in the functional heartburn patients. So the day-to-day variation in acid exposure time can change the diagnosis from non-erosive disease to functional heartburn or the other way around based on the long-term recording. These were studies that we did a long time ago with Ray Klaus that showed the incremental value of the second day in black bars in terms of all subjects, patients with typical as well as atypical reflux symptoms, and the increased symptom reporting that you got from the second day gave you additional symptom association probability in these patients. So the value here is in patients who have infrequent symptoms that may not have enough symptoms over a 24-hour period when you're trying to correlate symptoms with reflux episodes. The additional days gives you an advantage there. Correlates with acid, with LA grades. This is data published a couple of years ago, and you can see the trend of average day acid exposure. So this is when you get cumulative acid exposure, average per day over the 4-day study. You can see there is a nice trend as your erosive esophagitis assessment increases from A through D. So from no esophagitis through D and compared to controls. So it does follow this trend of increasing acid exposure when there is increased reflux burden. And here you see from the same paper the performance characteristics of prolonged wireless pH monitoring in segregating controls versus erosive esophagitis of different grades. And now, the clinical value, you've seen components of this study in different slides. I show it slightly differently here. So this was a study done between John's group and ours. These were patients who had incomplete response to PPI, and they all underwent endoscopy with 4-day wireless pH testing. But the patients and us as investigators were blinded to the results of the pH test. And the patients were told to resume their PPI if they couldn't handle their symptoms. If the symptoms were bad, start the PPI, but tell us, right? So it turns out that 3/4 were unable to discontinue their PPI, and a quarter, 2/3 were unable to discontinue their PPI, and a third were able to. And there were significant differences between these two groups, not just in terms of symptoms, but in terms of acid burden. The people who could stop their PPI had limited acid burden, whereas the people who could not stop their PPI had more than 2 days with acid burden above 80% of the time. So the odds ratio of the patient being able to stop their PPI if they had 0 of 4 days with acid burden less than 4% was 10. And remember, at tertiary care clinics, we stop PPIs more often than we start PPIs. So this is an important value of prolonged pH monitoring, that you can identify the people who don't need their PPI and need other forms of therapy. And the odds ratio of needing to continue their PPI when they had more than or equal to 2 days with acid burden more than 4% was 5. So this leads to this dominant pattern analysis of acid exposure. So what is dominant pattern? This follows some of the Lyon thresholds, and you look at concordance. You rarely have all 4 days having the same pattern. That's total concordance. But dominant pattern is more than 2 days, more than or equal to 2 days with the same pattern, whatever that might be, pathologic, physiologic, or borderline. And discordant is any other pattern. And if you look at patients as well as controls, with 48 hours, you have a third that are discordant. So in other words, up to 40% will have 1 day showing one pattern, and the second day showing a different pattern. Whereas if you add that third day, you'll just need the third day. If you add that third day, you get to 90% either concordant or dominant pattern, both in healthy controls and in patients. We collaborated with Mark's group for this. And again, if you look at this number of days with abnormal pattern or normal pattern, the ability of acid exposure time less than 4% to predict discontinuation, this is 24 hours, 48 hours, and you can see the jump at 72 and 96 hours. Again, remember, we stop more PPIs than we start PPIs in tertiary care clinics. So based on some of this data, this is the paradigm that is being followed or at least recommended in the US. So a typical patient with typical GERD symptoms, standard dose PPI, assess response. If they get better, wean to the lowest dose. If they don't get better, there is a role for increasing the dose to BID, assess response. If they get better, you move to the left side of the algorithm. If they don't get better, that's when you endoscope the patient. So if you bring the patient for endoscopy off PPI, this is something that can be done at that same setting. And John alluded to this in his talk. And I'm not going to spend too much time with this because John already showed this slide. And this is the paradigm of how you can use information from the endoscopy and prolonged pH monitoring in deciding what to do to the patient. So no GERD versus GERD. Obviously, if they have GERD, you're going to optimize them. And borderline, you may need more information. I'm going to skip that. So what are the pros of wireless pH monitoring? Easy procedure, can be done by a general endoscopist. And these days, the catheter does not need to be, the probe doesn't need to be calibrated. So you can pull out a probe at very short notice if you don't find enough evidence on the endoscopy itself. Interpretation is not as cumbersome as pH impedance monitoring. So as long as PPIs are held, this can be done relatively easily. It's ideal in patients who are intolerant of a nasal catheter. And it can also be utilized when your pre-test probability is so high and the 24-hour study is negative. So if you have a patient that you think has reflux disease and a 24-hour study is negative, this is a useful adjunct to be done. And obviously can be utilized in children and uncooperative adults. There are some artifacts and cautions. This is a patient who was drinking Mountain Dew, which is an acidic carbonated beverage, all day. And we found out after the fact, and you can see that it looks like it's an abnormal study. It really isn't. This is a probe that fell off. This patient was sent to me with a 56% acid exposure time. He's a lawyer, and somebody told him he needed emergent anti-reflux surgery. And when we took out the portion where the probe was in the stomach, his acid exposure time was high, but it's like 10 years later now, and he's doing fine on PPIs. Here's another one, less obvious, but this is also a probe that has fallen off. It didn't stay in the stomach very long, but you can see the duodenal pattern at the far right of the study. And this is a probe that was placed too low. This is, there is an operator element. You got to place it right if you're going to get good data. So this is dipping into the hiatus hernia. Now, there are other cautions. So nickel or cobalt allergy, defibrillators are considered to be situations where you would probably not do this. Diverticula, esophageal diverticula, varices are considered situations. I have placed them in patients with varices. You just have to be careful that you're above the varix or you're at least looking in the esophagus. It should be very rare that you'd have to do a wireless study on varix. And then the other issue, the patient who says, I just can't stand it. They call you back 2 hours later and say, get the damn thing off. And you can do that. You just need an endoscopy. The best way to do it is to try and pry it out with the tip of the endoscope. If that doesn't work, you put a snare, and then you try to pull it up rather than push it down, and you can pry it right off. If you try to push it down, you may shear the mucosa, and you probably don't want to do that. With that, I'm going to let Eduardo take over.
Thank you, Prakash. I would like to start saying three things. First one is it's an honor to be chaired by Peter and Daniel, who are two of my idols. The second point, it's true, I cannot debate with Prakash because I love him too much. And the third one is that I will copy and paste a little bit John, what he did this morning about the stimulation, the pharmacological stimulation of the esophagus. How many persons in the room can decide freely what to do at index endoscopy? Can you decide to do a Bravo pH, mucosal impedance, make a tour in the esophagus and in the stomach in this index endoscopy? Can you raise your hand? A few, really a few. That's probably one of the problem. The algorithm suggested by John was perfect, and in a hypothetical world is perfect, but unfortunately most of the people cannot do what they wanted in the endoscopy. So I'm starting to say that impedance pH is probably the best method, according to everyone, I hope, in this room, to detect reflux episodes, not talking about esophageal acid exposure measurement. And from a mechanistical point of view, is the best test to use for understanding which is the cause behind the symptoms. There are several advantages and limitations as compared to Bravo pH capsule. Some of them have been highlighted this morning and also in the talk of John and Prakash, but also there are some advantages, including the possibility of measuring non-acid reflux episodes, belching, and so gas movement, and of course study patient on PPI therapy. We also heard by Nicola de Bortoli this morning the opportunity to measure baseline impedance and PSPW. These metrics provide longitudinal marker of mucosal integrity and chemical clearance not affected by day-to-day variability and so on. The main limitation of 24-hour testing is partially overcome. As mentioned, we can do the test off and on therapy. We have lots of data suggesting that the technique is able to assess the relationship between symptoms and not only acid but also non-acid reflux episode. We had studied by Daniel Sifrim, by our group, by Frank Zerbib, and also Marcelo Vela, Radu Tutuyan, and the MUSC group. Of course, in patient study of PPI therapy, the additional diagnostic yield is about 10 to 12 to 20%, but increase on PPI therapy. We did some studies also demonstrated that the application of Lyon consensus criteria and the evaluation of conventional and pH impedance parameters, MMBI and PSPW, is helpful to identify patients with true reflux disease. And also we know that studying patients with atypical symptoms, mainly cough, can be done quite easily with pH impedance, with the ability to correlate symptoms with mainly with cough. Most of these studies come from Daniel and this group before in Leuven and then in London. Also, we have data from Chang group who show that the pH impedance is also able to predict the decline of pulmonary function in patients with IBS in the long term, suggesting that could be used a priori to predict the patient who probably will go worse during time. And we apply the same methodology in patient study of PPI therapy to understand if those patients who fall in the gray area with the pH between 4 and 6 and do not report symptoms during the testing day can be identified correctly by using MMBI and PSPW. And we found indeed that MMBI is able to correlate, to identify the true refluxers in this patient who fall in the gray area. Of course, we can study patients on PPI therapy that cannot be done with Bravo pH capsule or pH-metry alone. The correlation between symptoms and reflux episode is much higher because we know that PPI just convert the acidic reflux episode to non-acid reflux episode, and the diagnostic yield here increased to 20 and 40% of the cases. And we published 2 years ago in 2021 that the ability provided by pH impedance to measure not only the esophageal acid exposure, but also the number of reflux and the mean nocturnal baseline impedance can predict symptomatic response to medical and surgical therapy. I think that these slides summarize a little bit what I'm thinking about the use of pH impedance. The pH impedance provide all the information I need, or almost 90% of the information I need when I have to understand better which is the cause of the symptoms for my patient. So if there is a true reflux disease, if there is a reflux hypersensitivity, if there is no GERD, and I have to look to other condition explaining the symptomatology of my patient. We have also outcome data, but I will show you more about the outcome data in the next presentation I have in the next session. Here just a few slides showing that the analysis provided by pH impedance predict not only the response to medical therapy, but also to surgical therapy, is able to differentiate patients with reflux hypersensitivity and functional harbor, identifying those who are going to respond to citalopram or fluoxetine or neuromodulator more in general, and also identify those patients who are going to respond better to anti-reflux procedure, not only surgical procedure, as shown by the paper published on New England Journal of Medicine in 2019, but also links. Finally, don't forget the air. Unfortunately, most of our patients at behavior disorder have supragastric belching, gastric belching, aerophagia, and so on, and probably abelchia, but we will discuss about this later on. And the opportunity to measure the air in some cases is helpful to identify those patients who can benefit from CBT or other kind of treatment able to reduce the symptoms.
So Eduardo, when you do this, is your preference to do it on therapy or off therapy?
I usually do off therapy, and here there is another point I would like to underline, that between 80 and 90% of the patients who come for doing testing is refractory to PPI therapy, and when we do the test, 80% of them are not affected by gastroesophageal reflux disease.
Thank you.
So as you heard, each test has its place. So wireless pH monitoring advantages, performed during sedated endoscopy, comfortable to the patient, reliable distance from the EGJ, less impact on lives, on activities, meals. The patient's not going to sit in that recliner all day with a catheter in place. And you can get 96-hour data. But there are problems. Cost. Only can be done off PPI. Acidic swallows can resemble reflux episodes. It can fall off. You have to be careful. You have to look at the study. And there are a couple of cautions.
Of course, also pH impedance has some advantages, which is can be performed on and off PPI, high sensitivity for reflux episode, and of course, characteristic of a reflux episode can be characterized quite well with pH impedance. We have a better reflux symptom association, and we can measure the novel metrics as mentioned before. There are also some drawbacks because there is the need of doing manometry to correctly locate the probe. The esophageal shortening may impact on tip position. Recording is limited to 24 hours. There is a suboptimal impedance assessment in case of esophageal dilatation and stasis is uncomfortable, and I did it on myself, so I know it. And the automated evaluation is still ongoing.
But I think we can come together and try and decide who could benefit from one technology versus another. So it really doesn't matter if your pre-test likelihood of GERD is very high. Either test will give you good information. And so the additional metrics that you get from pH impedance will overcome the limitations of 24-hour study in these high pre-test likelihood situations. But wireless technique has particular advantages in patients who can't tolerate the catheter. With infrequent symptoms, you need reflux symptom association, high suspicion for reflux with a negative 24-hour study, especially if the 24-hour study is a catheter-based study, and in patients with a very low clinical suspicion of reflux disease. And pH impedance?
I mean, it's particularly useful in patient refractory to PPI, both typical and atypical symptoms. Refractory symptom of cough in patient with pulmonary disease, in patient with repetitive belching, to understand why there is this kind of symptoms, and if this belching also drives to have more reflux disease. In case of suspicion of rumination syndrome, in case of persistent reflux or increased belching following anti-reflux procedure. Thanks.
Well, I think we need a vote.
I think we do.
So, if you had the choice between doing an index endoscopy with a Bravo study off therapy, or doing a study and then placing the pH impedance also off therapy, and there are no economic considerations here, so you have the choice, how many would place the Bravo capsule? Yeah, you're asking too much here. How many would place the pH impedance catheter? I think it's slightly in favor of the Bravo.
But I've got another question. If you had to have the test, who's going to have the Bravo?
Or the other question.
And who's going to have the pH impedance? There's so many liars in the audience.
Is there a competition?
No, of course, that's the whole point. This was a love-in. They all agreed with each other.
Why is it one or the other?
It's not. It's a symptomatology.
No, it's great to have both.
So it's like, why is it one?
When do you?
You're going to put in a Bravo and the catheter?
No, the solution, John,
when
the
do
solution is one capsule that measures both pH and impedance segments. And this is in development at this moment.
Can I just add a little comment? I mean, in fact, from what we've discussed so far, there is no competition, because even if in the same patients who come for an evaluation, if your clinical history is so important, if you suspect belching or rumination, certainly you do pH and impedance. If you have a patient where you have a high suspicion of a functional heartburn, then you go on pH, the wireless one. So it depends. It doesn't compete. I use both of them.
Dr. Savarino, when do you need impedance? When do you need impedance?
Roberto already said this. In case, I mean, when typical symptoms, and there is also belching, when there is rumination suspicion, when you have a typical symptoms, and when you have a patient refractory to PPI therapy, I mean, you should go with impedance pH. But I mean, again, what Prakash, John, and Roberto was saying, this is not, there is not a single test able to say this patient has reflux disease and so on. We need more tests to understand more this patient, and if in my practice, if I would be able to do Bravo, pH impedance, manometry, ambulatory manometry, and so on, I probably would do everything.
You know, I think another consideration is that if you elect to do the Bravo immediately, you can do it without any manometry study. Whereas if you want to do the pH impedance, you have to do the other. So in essence, if you do the Bravo study up front, you may obviate the need for doing the pH impedance.
Yeah, but there may be a role for doing a pH impedance in somebody who has a positive Bravo. You treat them, they're still symptomatic, you're trying to make a decision about the next step.
Yeah,
I've done that in some patients where you do a pH impedance and then if their pH impedance is abnormal, then you move on, you're more aggressive with managing them.
Hi, Nir from Tel Aviv. What is the place of on PPI tests in your eyes at the moment? Because I saw most of them were off PPI, either Bravo or pH impedance, which is probably...
So I will tell you that there is no place for on PPI Bravo. You should really not do it. You want to talk about on PPI?
Can't tolerate a catheter, and you have to see if their PPI is working.
Sorry for interrupting, but there's a question from Salah Balint.
Hey, Prakash and Edo, this is Daniel Pohl from Zurich. Thank you for the presentation. Prakash, two things, comments and maybe questions. Number one is the less likely GERD is, if you put in a Bravo, the more, as you said, likely you have a functional disorder. And in about 5% of my patients, they have rather intractable pain towards the Bravo. And the more Bravos I do, and I really do a lot of them, the more this becomes a problem. About once a week, I have people calling the ER and so on. And so I try to manage them with, paracetamol and Novalgin and try not to rip out or do a little mucosectomy, basically, with a snare. So I wonder what's your take on that, also in terms of information of the patient, because whenever we talk about the Bravo, we talk about how comfortable it is, and really for some patients it's really a pain. And the second thing is, which is not being discussed, is that if they're on anticoagulant therapy, which a lot of the elderly chest pain patients are, right, then this is also an issue because you have to take them off. And I wonder what's your point on that?
Okay, so the anticoagulant issue. So for the endoscopy, if they're on a true anticoagulant like warfarin or Eliquis, I take them off, but then I put them right back on after so I only take them off for the endoscopy. The issue with the pain, we actually looked at that before. The people who hurt probably have a hypersensitivity issue, and their acid burden is not going to be high. So if you can get a few hours or a day out of them, that's usually worthwhile. I do the same thing you do. I give them analgesics, and once in a while, I'll give them some lidocaine to just tide them over the first few hours, and then try to get as much data as you can. You want them to punch buttons every time they use it, and I tell them they can't just keep doing it, you know. And sometimes if they complain of pain for too long, let's say we're 3 days, 4 days, and they're still complaining of pain, I tell them to eat a bagel, you know, very hard bread, and usually it knocks it off.
So I think one of the things that we forgot was that the reason the Bravo was developed by Endonetics was because of the discomfort of the probe. And there were many studies showing that patients that undergo probe instrumentation, it affects their reflux-provoking activities significantly. And I don't think that comes back again when we talk about impedance plus pH, because we are back to the impedance plus pH after the Bravo was developed, and we never see any discussion about the impact of the impedance plus pH on patients' reflux-provoking activities and how much it does truly represent patients' experience.
But that's true, Ronnie. This is a limitation of every catheter-based test. On the other hand, I can tell you that the artifacts that Prakash showed us, like drinking Coca-Cola for 96 hours during the Bravo pH capsule, can be completely eliminated by the fact that I see during impedance that you are drinking Coca-Cola. And so I can tell you that you are stupid because you are drinking Coca-Cola during the test. So.
Perfect. Shall we all go and drink something ourselves now?
Let's go.
Let's break for that.